Calculating the biological and economic impact of a single 80-cent medical tablet requires tracking its ripple effects over more than 20 years. In 1998, in the rural Busia district of Kenya, over 90% of primary school students, kids aged 8 to 15, were infected with intestinal worms. Researchers launched a randomized controlled trial across 75 schools. Using list randomization, these schools were assigned to either receive free deworming medication immediately or to serve as a delayed control group. Standard public health programs evaluate these interventions by looking for immediate gains. They check if the treated children gain weight, stay in school longer, or have fewer infections over the following few years. But measuring only short-term outcomes ignores the actual timeline of human development. To capture the return on that initial health investment, we must track those original students until they grow up and have children of their own. Tracking an entire cohort of students from childhood into their late 20s and 30s requires rigorous long-term observation. Researchers built the Kenya Life Panel Survey to continuously follow thousands of these original participants. This allowed for the measurement of a distinct new metric, the under-5 mortality rate of the next generation, the children born to the kids from the 1998 study. This chart plots child mortality rates over time. The blue line represents the control group, perfectly tracking the slowly declining Kenyan national average shown in gray. When we plot the data for the participants who received the deworming pill, the treatment line in orange drops distinctly below both. That gap represents a 22% drop in under-5 mortality, equating to 17 averted deaths per 1,000 live births. A temporary medical treatment given to a 10-year-old leads to their future child being 22% more likely to survive infancy. Mapping the causal mechanisms at play explains how that transmission occurs. The first concern with a 23-year study is whether this is a statistical illusion. Specifically, researchers checked for attrition bias, the possibility that the unhealthiest individuals simply dropped out of the survey over time. The panel data rules this out. The researchers maintained contact with the original cohort, achieving an effective survey tracking rate of nearly 87%. Panel B demonstrates that annual consumption expenditure, a direct measure of adult living standards, rose in perfect tandem with the amount of treatment received. We can also rule out fertility changes as the driver. In Panel C, the total number of births per person remained relatively flat across all treatment levels. The data confirms the mortality drop is robust and causal. We can now map the behavioral shifts that occur as these children grow into adulthood, tracing the pathways that lead to higher child survival. The intervention triggered a series of behavioral and economic shifts that diverged sharply along gender lines. In the female cohort, the first link in the causal chain is formal education. Girls who were treated extended their schooling by an average of 0.43 years and were 7.6% more likely to attend secondary school. Spending more time in the education system naturally delayed their age at first birth, creating a more mature biological environment when they eventually had their first child. These educational gains also influenced subsequent healthcare behaviors. Mothers with more education are better equipped to navigate modern medical systems and advocate for clinical resources. This is confirmed in the clinical reality of the treated group. These women utilized significantly more antenatal care and saw a 4% increase in institutional deliveries. This behavioral shift compounded with biological improvements in the mothers themselves, who reported higher baseline health and experienced a measurable reduction in miscarriages. For the female cohort, the deworming medicine functioned as an education multiplier that structurally upgraded how they accessed and utilized maternal health care. The male cohort contributed to the 22% mortality drop through different socioeconomic levers. For men, the primary mechanism was economic leverage. Treated males experienced a permanent 14% increase in per capita consumption expenditure. A 14% bump provides a household with the purchasing power necessary to secure reliable food sources, maintain hygiene standards, and absorb economic shocks. This added economic capacity translated into geographic mobility. Treated males were 4% more likely to migrate and reside in urban areas. Urban residence provides vital structural advantages. It brings the household into closer proximity with paved roads, formal sanitation networks, and emergency medical care. The causal architecture is precise. Females optimize their children's survival through formal education and clinical healthcare, while males optimize survival by acquiring economic power and moving closer to physical infrastructure. Combining these pathways reveals a conclusion. This mortality drop is a multi-sectoral dividend on human capital. This raises a critical question for global policy. How do governments and development organizations value an 80-cent school health program? Traditional accounting typically only prices in the immediate health benefits and the individual labor returns of this specific child who took the pill. Economists use disability-adjusted life years, or DALYs, to assign an economic weight to health outcomes. To find the true return on investment, we must calculate the economic value of the DALYs averted by saving the lives of the next generation. This chart models that comparison on a logarithmic scale. An annual 83-cent drug cost generates an estimated intergenerational benefit of $381 per year. Even using hyper-conservative revealed preference models, the monetary benefit still consistently outperforms the initial medication cost. When global policy frameworks ignore these generational spillovers, they systematically underfund interventions targeting adolescents. This brings us to the 23-year study's mathematical conclusion. The social internal rate of return yields between 41 and 124%. An annualized 41% social return easily dwarfs the financial yield of almost any traditional infrastructure or global market investment. Interventions during the adolescent growth spurt yield a triple dividend: immediate health improvements, long-term adult prosperity, and their future children's survival. A policy decision made for a 12-year-old today dictates a nation's vital mortality statistics decades later. We can no longer evaluate global health programs exclusively through the lens of short-term election cycles or 3-year grant windows. Human capital is transmitted across time. The data shows that an inexpensive childhood pill functions as one of the most powerful